All right. Good morning, everybody. Can everybody hear me okay? Yes? Okay, awesome. Um, we are going to start with a land acknowledgement. So the Coalition for Health Equity recognizes that the UC Davis Health Campus sits on unceded or stolen land inhabited by the Plains Miwok, Nishanen, and Southern Maidu nations. Additionally, the UC Davis campus was established on unceded Patwin land. We acknowledge that the nations continue to struggle for tribal sovereignty to this day, and that expansion of capital interests into the homes of marginalized communities is an ongoing pattern that did not end with seized native land. This acknowledgement is a small step in honoring Indigenous peoples who have historically been denied many educational, civic, and economic opportunities.
Hi everyone, how is everyone doing today? I hear goods. Welcome to the 2020 Annual Coalition for Health Equity Conference at UC Davis. My name is Wendy. I'm a nursing student at the Betty Irene Moore School of Nursing at UC Davis. We're excited to have you here. A little bit about us, the Coalition for Health Equity, or CHEq, is an interprofessional student group consisting of medical and nursing students. We aim to mobilize a diverse group of community leaders in partnership with community members to create innovative solutions that address current health equity issues. By fostering awareness, advocacy, and collaboration, our mission is to unite our community around the common goal of improving health outcomes for all people. And for our safety announcement, we're present at the Betty Irene Moore Hall in Sacramento. Our team of 15 are present at the Betty Irene Moore Hall, room 1000, which usually sits about 450 people. We're practicing social distancing guidelines, seated 6 feet apart with our masks at all times and plenty of hand sanitizer. We're excited that this is our first virtual conference. As this is a student-run conference, we appreciate your patience in the event that we have any technical difficulties. This is our agenda today. Our opening session will be held in the main room. Then we will have 2 breakout sessions where you'll be able to choose one of 4 speakers per session. If you're wondering how you could possibly choose between our speakers, I totally understand. I don't know how I could choose either. All sessions will be recorded and uploaded so you can watch all of our speakers later. After our breakout session, we will all return to the main room for our closing session. Stick to the end because we'll hold a raffle for our participants who stay. I'll pass it on to Melissa regarding the format of the conference.
Hello, everyone. My name is Melissa, and I'll be explaining some of the logistical items before we get started. To identify a CHEq member, if you need help, you can chat with any of the people wearing a CHEq face mask, or look at the name labeled with CHEq in brackets. So what is the conference layout? This conference isn't like other Zoom webinar formats where you can only see the speaker and the speaker is just presenting in an open space. We are utilizing Zoom breakout rooms so that each speaker session is a little more interactive and the speakers will get to see the participants. To put you all in the correct breakout rooms, you will be changing your name according to the speaker you want to see. If the people you want to see today are different than what you registered for, then that is fine. This is why you will rename yourself. To change your name, and you can follow along while I explain this, you will hover over the bottom of your Zoom screen and click this participant button. Then you will write your name at the top of this next window that should look like this. You'll click more, and then click the rename button. You'll then type in the room number that you want to see and your preferred name. So for example, if you want to watch Dr. Ruth Shim for session 1, you will change your name to put a 3 in front of your name, and then the rest of your name right there. Second example, if you want to see Jay Chenier for session 1, you could put a 2 in front of your name. Don't worry if this is a little bit confusing right now. We will show this slide again. For the time being, we'll be moving on to our opening comments. If you have any questions about how to change your name, you can go ahead and chat me in the chat box below, and I can help you further. Back to you, Wendy.
Thanks, Melissa. We'll start with our opening comments now, and it is my pleasure to introduce the Chancellor of UC Davis, Gary May, to share a few words.
Hello, everyone. It's a pleasure to be here at our student-run Coalition for Health Equity Conference. Actually wondering how I can get one of those cool CHEq masks, but maybe mine is in the mail. I want to thank all of you for the important work that you're doing to promote health equity and better serve all the members of our communities. This has really been a year unlike any other. The COVID-19 pandemic has turned our world upside down. If that weren't enough, we've had to contend with another year of devastating wildfires and unhealthy air quality and sustained social unrest in cities across the country. So I'm proud of the leadership and the innovation that UC Davis Health has shown during this public health crisis and their ongoing efforts to do even more to serve the underserved, because that's part of our mission. But we can always do better. And I think that with our leadership, we can and we should serve as a model for others. The pandemic's impact on our economy, its disproportionate impact on communities of color, and the extent of nationwide protests following the police killings of George Floyd, Breonna Taylor, and many others, all point to ongoing inequities for people of color. Higher education can be part of the solution, though. Academic leaders are in a unique position to bring access, opportunity, and advancement for everyone. And that's how we build a better tomorrow. Social justice has always been a driving force for me and my family. My mother was among the very first group of students to integrate the University of Missouri back in the 1950s during the era of Jim Crow. That seems like a long time ago to many people, but for me, it was just one generation ago. As much as we like to think that we've made progress, the numbers tell a different story. Across the 10 campuses of the University of California, for example, nearly 70% of tenured faculty are white, almost 17% are Asian, about 7% are Latino, and 3% are African American. Now compare that to the pipeline of students in our public schools. More than half of the K through 12 public school students in California are Latinx. So this is not a new issue. When I was an undergraduate at Georgia Tech in the 1980s, I was often the only African American in labs and classrooms and lecture halls. When I finished graduate school at UC Berkeley in 1991, I was one of only about 30 African Americans that year to earn a doctorate in engineering. That's 30 in the entire United States. You could fit us all in a single classroom. The same goes for academia. When I joined the faculty at Georgia Tech, there were not many African American faculty members. I remember once very early on, someone came in and started giving me instructions on what was wrong with the copy machine. They assumed I was there to fix the copy machine, that I was the repairman instead of a faculty member. So people still don't expect to see someone like me in higher education leadership, and they don't expect to see other underrepresented minorities or women. And I'm sure many of you have had similar stories to tell. I believe that embracing diversity and inclusion is central to our humanity and our progress as a society. And let me be clear, diversity is not just a buzzword. We champion diversity, equity, and inclusion, not just because it's the right thing to do, which it is. We champion diversity because it results in better outcomes. Diversity drives innovation. It's at the root of technological advancement. Diversity also ensures that our innovations for things like smart technology and healthcare solutions serve all people across the full spectrum of backgrounds. For example, we know from research in the health field that diversity leads to better outcomes in medical care, research, and education. We still have work to do to reflect our increasingly diverse student body. How do we do that? Well, there are things that we can do, and I'll just mention a few. First, I believe that diversity is everybody's job. We can all do our part in supporting others and creating an inclusive environment. Diversity, equity, and inclusion have to be a part of our strategic plans. And by the way, it is a key priority in the UC Davis plan. We also need to ensure that we have diverse candidate pools when we hire faculty and staff. We need targeted programs to recruit and retain and help students succeed. We need to work with the community on pipeline programs. And that's how we tackle some of the educational barriers that impact underrepresented students. And finally, we need mentors and role models among faculty and leadership. There's a quote that's always resonated with me from Jocelyn Elders, who's former Surgeon General of the United States and an African-American woman physician. She said, quote, "You can't be what you can't see," unquote. It's clear that we need to do a better job of providing access and opportunity for underrepresented groups, both in higher education and in healthcare. So let me wrap up by saying I appreciate the work that you're doing here to be a part of the solution. The world needs you now more than ever to keep our communities healthy and to ensure that everyone has access to quality care, regardless of race, gender, orientation, citizenship, or socioeconomic class. So have a great day and enjoy this conference, and thank you for having me.
Thank you so much, Chancellor. We really appreciate your support and being here on a Saturday. I'd like to welcome our next opening speaker, the Associate Vice Chancellor for Health Equity, Diversity, and Inclusion for the UC Davis School of Medicine, Dr. Hendry Tan.
Thank you so much for that welcome. And thank you, Dr. May, for those inspiring words of leadership and your call to action. I also want to thank the CHEq organizers for the kind invitation for me to join Chancellor May and Dean Brashear to share some opening remarks, and to the conference participants as well. I want to share with you a conversation I had with a patient that really helped me to think about health equity. "I can't sleep, Dr. Tan. I can't sleep." I remember those anguished words of a Vietnamese man stricken by PTSD and depression, highly prevalent in Southeast Asian refugees, not because of a biological predisposition, but the product of social political upheaval. War and violence are terrible social determinants of health. We teach our students and residents that insomnia is a sign of depression, a complication of PTSD, and that behavioral changes like sleep hygiene and medications are the solution. This is what I learned as a psychiatrist. But the issue was less that he could not sleep, but rather that he could not afford to sleep. Afraid that he and his family would be hurt or killed by the violence that endangered his neighborhood. Fearful that they would be defenseless targets of harassment because of their ethnicity, their accent, and their spoken language. While providing him with medications would have helped him with his sleep, it ignores the deeper issues, and ultimately it ignores his humanity. Essentially telling him, "I hear your fears of being hurt. I hear that you do not want to leave your family defenseless in their sleep." And then to ignore that, to ignore the essential need for him as a living and loving being to be safe, to know that his family will be safe by me prescribing medications, to say, "I hear that you shouldn't sleep because you're afraid, and here's a medication for you to sleep." Yet this is the cycle that we healthcare professionals and our patients are regularly caught in. Several years before seeing this patient, we had worked with community partners, with the county, and with Sac State to build our clinic, the Transcultural Wellness Center, from the ground up to uplift the whole person and their family. And we regularly set aside funds to address such determinants of social determinants of health. And we used those resources to find him safer housing. We helped him to move to that safer place and paid for his deposit. For several years afterwards, his sleep improved, his depression lightened, and his PTSD was less triggered because he felt safer and was indeed safer. What could have cost our clinic and the public lots of money costed less than $1,000. And most importantly, it honored his dignity and eased his suffering. But what about the others in the neighborhood? Is the true solution to move people out of distressed neighborhoods? And what about the people's historic and cultural roots and their connection to the neighborhood and the community? To force a person to choose between their own health and the places that they call home and community can have deep and devastating impact. And some don't have choices to stay or to leave. As a doctor and a refugee, I've seen and experienced this kind of pain. The lesson here is that in order for us to truly achieve health equity, we have to go beyond just treating the biological manifestations of health problems. We have to address the social roots of health, to go beyond just helping patients, families in our clinics, but also to extend our reach to the support of the communities that they live in. And research confirms this. 40% of health is connected to a person's social and economic circumstances. We see this in our surrounding neighborhoods at our health system center in Sacramento. In our South Sacramento neighborhood where my patient was from, and the Oak Park neighborhoods that are just a stone's throw from where we are. Both are within walking distance and biking distance of 3 major medical centers. Yet our residents experience some of the most significant health inequities in the state. The life expectancy of a person living in Oak Park is 10 years less than someone living at Davis. 20 miles distance, but a decade of life lost. For us to truly improve the health of communities, we have to do more than just endeavor to be the best providers in our region. We also have to continue to improve health care access, but that's not enough. We have to use our health expertise and our collective voice to call attention and to fix structural racism and inequities that underlie the health disparities experienced by oppressed communities. And we have to examine the very ways that we function as organizations. We are organizations as health systems, as government, as businesses. We are organizations that move economic capital. We have to leverage our resources to improve the economic vitality of underserved communities, especially embracing our role as an anchor institution for communities that are buffeted by socioeconomic instability. So this is the goal of our anchor institution mission, or our AIM for Community Health Initiative. By developing and supporting jobs for local community members, partnering with local women and minority-owned businesses, and purchasing and investing locally, we can help generate prosperity that stays and grows within communities, and thereby addressing these underlying roots of health. The good news is that health disparities have been improving in the United States, although they're still evident and quite significant, as I've illustrated before. But I believe that we are at a turning point in our country. There's broad acknowledgement in the health community that health disparities exist, unlike discussions that I've had with colleagues 10 years ago. There is growing understanding that there's a relationship between racism and other social determinants and the profound impact that it has on the health of individuals and communities. Many have devoted their careers to addressing these inequities, and more are joining our efforts. So whether you work in this work for 10 years or 10 months, for a lifetime, or you're just starting out, I hope you come away from this conference with the hope that change can happen, with the inspiration to be part of that change, and with the tools to make it so. Thank you.
Let's have another quiet round of applause for Dr. John. Thank you so much for sharing your stories, your words. As many of us are just starting out, we're really excited to embark on our journeys as up and coming healthcare professionals. I'd like to welcome our last opening remarks speaker, the Dean of UC Davis School of Medicine, Dr. Allison Brashear.
Good morning. Thank you, Wendy, and thank you to the Chancellor and to my friend Henry, who really got the conference off to a wonderful start. First, I want to thank all the students who planned today's conference for their hard work in making this important event possible. The current pandemic really focuses on the impact on underserved and vulnerable communities. And this underscores the vital importance of our mission to eliminate health inequities. Essential to improving health inequities is a diverse workforce. This workforce should be teams with wide-ranging skills and cultural background. I know that teamwork is incredibly important to the group here that put this program together. And the School of Medicine is promoting multidisciplinary teamwork in all that we do, our research, teaching, and patient care. We partner daily with the School of Nursing and the other schools to bring together new ideas. We know that bringing together diverse teams brings new ideas, and new ideas drive innovation. And nothing showcases that like our strengths in multidisciplinary research like aging, cancer, stem cell, drug discovery. I just want to make sure everybody stays tuned for a big announcement next week about team science and aging. Teamwork is really important in teaching, and it's reflected in our new School of Medicine curriculum. Our new I Explore curriculum, which, as I think most of our students know, was approved in the middle of the pandemic, will begin in 2021. And I Explore emphasizes inclusion and cross-disciplinary collaboration. The School of Medicine is really centered about patients. Our students are studying to be physicians, and as physicians, they may be in the lab, the classroom, at the bedside, but central to any of that work is patients. And like many of us, our students may end up doing all three. The School of Medicine is proud to be ranked number 7 in primary care in the country by US News and World Report. That means we're a leader in training doctors who provide direct patient care. Now, this conference is about health disparities and how to improve the future of health for some of our most underserved communities. And I believe one of the best ways to do that is to train a diverse workforce who provide care to our communities. Our School of Medicine is number 7 in primary care, but we're also a national leader in student diversity. And while the School of Medicine faculty has increased in underrepresented groups from 2016 to 2019 by 40%, that denominator remains far too small. We're taking steps to ensure that our faculty also reflect the diversity of our students and our community, and this is a priority for me as the Dean of the School of Medicine. Each of our department chairs have been charged by me to develop plans for recruitment, and Dr. Ton and I are working together weekly to make these plans a reality. We know that when doctors understand the frame of reference of their patients and their families, that the patients and the families are provided better care. And nothing has shown this more than COVID-19. It's vital that we assure that everyone in our community has access to patient-centered care and potentially life-saving treatments. One of the ways the School of Medicine has been doing that is through clinical trials. I'm excited to share that for the COVID-19 trial that we're participating in, we were able to partner with the community, work with Dr. Ton and many others to enroll patients who mirror our community. We had tremendous support throughout North Carolina. We had an overwhelming positive response with 3,500 people signing up for 200 spots for this vaccine trial. The diversity of the patients we enrolled is unheard of in research, and it really reflects our strong community bond with the School of Medicine to really change the trajectory of healthcare and how we provide healthcare to everyone. So one of the things to advance health inequity and to promote an environment that's inclusive of everyone is by convening key stakeholders like this conference to share diverse perspectives, as you're doing today, to listen, share, learn, and most of all, translate that into action. So the School of Medicine this month will be featuring a speaker series for students, faculty, and the public with Dr. Valerie Montgomery Rice. She's the Dean of the Morehouse School of Medicine, and she'll be here on October 11th and 12th, virtually though, and she'll be focusing on health inequity and social justice. So we'll hope you join us for that interactive event as well. Her talk will be on the School of Medicine Facebook Live. So I want to thank again the organizers of this important conference, but most importantly, I want to thank you for your commitment to advancing health equity. I look forward to working with everyone to improve the health and well-being of our community, and I hope you have a wonderful conference this morning, and thank you again.